Good evening, good people. Apologies for being late, but since we set out this objective to discuss Ebola, tonight we are joined by an amazing guest. He's called Peterson. He's not new in the health space as he chairs or he comes in as the chairperson of the Kenya Union of Clinical Officers, and he's also the chairperson of the Health Caucus Associations and Union in Kenya. He also is a clinical nutritionist, and I will allow him to introduce himself. But before then, allow me to introduce the topic and why we are having these discussions. So, for the last few weeks, I'll call it, we have had a lot of noises about Ebola, and we've even had arrests or people on arrest, like commotions in regions like Nanyuki, like Kipia County, where we've been having demos. And we've also had planned demos on the same, where people are saying that the government, through the Ministry of Health, is planning to import Ebola to Kenya. And as a healthcare worker or as a healthcare professional, some of us might understand the severity of the disease, others might not. And that is what you're going to discuss today. How prepared are we as a country? So, Washira, as you introduce yourself, kindly you can also just give us general outlook of the situation before we start the discussion, so that we can now start understanding what is Ebola and why is it that now we as Kenyans have been worried about this condition or this disease coming to the country, where it's stemming from and all that. Karibu sana to our platform. My name is Lilian Momina. I'm a registered clinical nutritionist. My partner, Charity, she's held up a bit, but I hope she will join us before we end the session. So Ashira, karibu sana. Karibu sana.
Thank you. Thank you, Lillian, and a very good evening to all the viewers and listeners to the Nutritionist Corner. And it's a very good thing you're doing. This is a channel that is very informative to Kenyans. It's also a very good opportunity for us to deliberate about a conversation that has been ongoing regarding Ebola. And other than myself being the chair of Kenya Union of Clinical Officers, I'm also an Ebola warrior. We call ourselves Ebola warriors. In 2015, a contingent was sent to West Africa. Myself, I was in Sierra Leone, where I was a team leader. We fought Ebola. We came back unscathed. We survived, and we defeated Ebola. So it's not something to be feared, really. It's something that we can be able to surmount. So Ebola, what is Ebola? Ebola is a viral disease that can be fatal, with a fatality rate depending on the type of Ebola you have, the strains. We have different strains for Ebola virus. And maybe just a bit of history is that Ebola virus was discovered in 1976, where it was isolated from some primates, non-human primates, that is the monkeys, gorillas, and chimpanzees, but now in the Congo it's the monkeys. And that was in 1976 near Ebola River. Ebola is a river inside Congo. And then after it was isolated, they went further to look at where the monkeys were getting this virus, and also the rodents. And they found that the natural reservoir were the fruit bats. So the fruit bats had Ebola. They would put their droppings on whatever wild fruits and berries the monkeys were eating. The monkeys would get from there, and then there are communities around Congo that feed on monkeys. And that is how then, because it is zoonotic means that it can be transmitted from animals to humans through eating monkeys. That is how then it came into humans. And the commonest strain is the one we call Zaire or Zaire virus. And it's basically named after Congo because Congo was previously known as Zaire. Then we have 3 more that can cause disease in humans. We have Bundibugyo, and that is the one that is causing the outbreak in Uganda and Congo, originally in Congo, then of course cross the border to Uganda. And then we have the Thai forest and we have the Sudan virus. They are all named, they carry the names of where they were first identified. Like the Bundibugyo was first isolated in Uganda. The Bundi is a district somewhere in the bordering districts to Congo, and that is where it was isolated. But mostly the major outbreaks will come from 3: the Zaire strain, the Bundi, and the Sudan virus. The Thai forest has not been associated with outbreaks, but we also have some other strains that actually do not cause any disease in humans, like the Reston strain. Of importance to note is that we now have a vaccine, but the vaccine is only for the Zaire strain. And so, in the current one, the Bundi, we do not have a vaccine yet, but there is a vaccine that is under trials. We hope that in future it will be available. Even the vaccine for the Zaire only came after the 2015 outbreak, which killed more than 11,000 people. And that is how then the world came together to produce a vaccine to at least prevent another outbreak from happening. So how do you know that somebody has Ebola? Ebola can also be transmitted now from human to another human once you get it from the animals. And usually it will be transmitted through contact. And that means it is not airborne. It is through contact, that is contact with body fluids, and usually we'll get in through the mucous membranes. Mucous membranes are found in the eyes, in the nose, in the mouth. Of course, another areas that have the mucous membrane, meaning that it can also be sexual. For those who have Ebola, they can be able to transmit it also sexually. And actually, it remains in semen for, it has been recorded up to 6 months. And there are somewhere where they have noted that it can even go up to 12 months. So when one is infected, it depends on your immunity. And depending on your immunity, the incubation can range from 2 days to 21 days. That does not mean that everybody who gets Ebola will take 21 days to show symptoms. Incubation period is basically the time that you take in between the day you get the infection and the day you show symptoms. So that is 2 to 21 days, meaning there is somebody who will show symptoms in 2 days. There is somebody who will show symptoms in 5 days, in 10 days. But the longest period that has been recorded has been 21 days. And during this period, the person does not know they're infected, and they cannot also transmit to another person. Then after that, depending on your immunity, you go into the second one, the second stage or phase, and that starts with the constitutional symptoms, which we call a prodrome. And that means you have signs that are not very specific to the disease. Usually some bit of fever, you're going to have muscle pains, weakness, extreme weakness, anorexia, you don't want to eat. You're going to have, in West Africa, majority of people who came at that point, they had tonsillitis or pharyngitis. And many, like, in Kenya, if you don't have any history that this person probably came from an endemic area or may have had contact with somebody from there, that will pass for pharyngitis or a tonsillitis, and they'll say the fever and the myalgia and whatever is coming from that, and treat that and go home. So after the constitutional symptoms, then you go into the what we call the wet symptoms. And the wet symptoms usually come from the effects or when it affects the gastrointestinal system. And that is where now you get diarrhea, vomiting, and then because of the now viruses are replicating very fast, then you're going to get a lot of fever. We call it a cytokine storm that causes a very high fever, profuse sweating, and they get a lot of headaches, and the eyes will be very red. Sometimes they can get a rash, which you cannot appreciate in a dark person because they are very small rashes. And then what will follow if it's not managed still is that you're going to have multi-organ failure, and it affects all the organs from the brain to kidneys to liver, and especially has a very big effect on the hepatocytes, the liver cells, and the association with the hemorrhage. We call them viral hemorrhagic diseases. As in lay language is to say viruses that can cause bleeding. And usually the bleeding comes from the destruction of the liver cells, because the liver cells, they help in producing some of the things that help us not to bleed, if I can say that in lay terms. So, but the bleeding is usually a very late sign, especially the overt bleeding that you see from external. The internal one starts early. You may not be able to note it. By the time probably they're having diarrhea and vomiting, and that stage, probably they have already started the internal hemorrhages you can't see. By the time you're getting overt or obvious bleeding that you can see from outside, this is a person who recovery is actually more difficult than death. And so then you can either recover or you can pass. And if you recover, there is a complication of uveitis, uvea in the eye. So sometimes they have a lot of pain in the eye when they recover for some time. That is something that was also observed. And I think I must say that Bundi is not as aggressive as Zaire strain that was in West Africa, but that does not mean that it's not fatal. Its fatality rate is between 25.4 to 50. I think right now we are at 25.4, meaning for every 100 people who are infected, currently 26 of them are dying. And that's a very big number. You can imagine if you have 1,000 people and then you're losing around 250 something people, that is a very, very big number. And of course, it is something that you can also be able to protect yourself from. Normally, the things that we were doing during COVID-19, the things we were doing during COVID-19 are things that we were supposed to have continued doing as Kenyans. Hygiene is not something that should be done during an outbreak. Hygiene is something that should be a normal thing. But of course, there is a bit of enhancing that usually now during outbreaks like Ebola, you avoid contact. We may not have reached there now because probably we don't have community spread. But when that reaches here, then the social distancing or the physical distancing comes in, and you have no contact like during COVID. Of course, masks when you're sneezing or coughing, because though it's not airborne, droplets that you disperse when you're sneezing or coughing are still going to cause infection. And of course, ensuring that anybody who is sick, you don't touch them, you ensure that they go to a facility. So Lillian, I think that is broadly about how you can recognize and how you can be able to, you can also be able to protect yourself.
Thank you, Daktari, for a very elaborate introduction on what Ebola is. And I like the fact that you have given us you have painted the picture of what is currently happening and the fatality rate and the aggressiveness of the current strain. Because word on the ground is that the government is risking and exposing Kenyans to a very aggressive strain of Ebola. And as you have confirmed, we do not have vaccines for that. So that, I think that is the main reason why we have been having some arrests. But before we talk about that, let's talk about now the condition or the disease, the outbreak is in another country. Like Congo is like we have the cushion of other few countries before we get to DRC as a country. Why is it that we are supposed to be prepared, or are we really prepared for this pandemic as a country? Are we prepared for it? Are we prepared for Ebola if it was to be established in the country? With the fatality rates that you have established, 26% is quite a big number. And the aggressiveness is also established because inamaliza watu vibaya. So how prepared are we as a country? What are the loops? We understand our healthcare system in a very good position to kindly elaborate on how preparedness. And Suleiman, thank you for joining in from Mali. Suleiman is listening from Mali. Welcome. Welcome, and I hope you get to learn a thing or two from our speaker about Ebola. You can also share in the comments about what is currently happening in Mali when it comes to preparedness, when it comes to understanding the condition, because we believe that you cannot contain what you don't understand. So as a country, how well are we prepared? How well have we put in measures to make sure that we protect our public against this very aggressive virus disease? Chair,
Yeah, thank you.
Washington?
Yeah, thank you, Lillian. And I agree that there is a conversation, and there is something very unfortunate happening that is happening because we are having a situation where we have a disconnect between the people and the government and the measures that are being taken. Let me start by saying that once an outbreak of the magnitude of Ebola is declared a fake means public health emergency of international concern. It means that the WHO have evaluated and have seen that it has the capability of moving from that country where it is endemic into other countries. And you saw it had already gone to Uganda. And we must thank Uganda. They're actually our buffer zone. They are really helping us. But then, I don't know if you ask the viewers here how many Congolese citizens they have seen near them or in their hood. We have a good number of them, and some of them undocumented. We don't know where they come in through. We don't know where they
And they
came
come
from.
in every day.
Yes,
Actually, they come in every day, yeah. Even now.
yes, and they pass through some of the borders that are not manned, and some of the panya routes into the country. And we don't know where they are coming from. They may be coming from Ituri province, where this is endemic, or North or South Kivu, where we are having a bit of these cases. So basically what I'm trying to say is that we are at a higher risk. We still have flights coming from Congo. We have buses that are coming from, maybe not from Congo, they'll travel to Uganda. Then from Uganda, they're going to take a bus. At the border, they'll use other ways to cross. And so we are still at a high risk. And in the classification, being that we are in the region and we are in the larger transport corridor of East Africa, where we have many of our drivers who are going to Congo. We have many gold traffickers, people who do their entrepreneurship in the gold region. They're still there. We have so many Kenyans there. And we have so many Congolese who are coming here to bring goods. So we are still vulnerable to getting this. But why I'm saying it's unfortunate is because we are not applying, especially in the case of Nanyuki, because, the assumption from the government is that Kenyans are rejecting this facility because it's US based. But if you are keen enough to listen, what we call social listening in risk communication and community engagement, and you listen to what the people are saying, the people do not care where this quarantine is coming from. What the people are asking is this thing going to bring Ebola in Kenya? They have the fear that this facility is going to bring infections in their community. And the government is not listening. Instead of answering the question, they are bringing in police, they are using force. And that is why you are seeing that disconnect is now leading to deaths. We have, I think, 3 people now have been shot. People who are fearing to die from Ebola, now they are dying from bullets. That is very unfortunate because we were supposed to just do a very simple thing: send a team of qualified health promoters and the communication personnel who are qualified in risk communication and community engagement. And we have a good number that we were with in West Africa, so that they go to the ground and they allay the fears. They tell people the facts that let us leave the issues of the US and Kenya aside. That is a political issue. But now, when we are addressing the issue of a quarantine facility, the quarantine facility is the safest zone for the society. Why? Because number one, there is nobody who moves out of the quarantine unless they have been certified to be negative, that is after quarantining for more than 21 days, and with more than 2 negative Ebola tests. And that includes the medics. If you are a medic working in a quarantine facility, you don't go home. You stay there, and the day you want to go home, you must be quarantined for 3 weeks. Then you take Ebola tests, at least 2 of them. It's only when they are negative that you can be able to go home. And the other point is, quarantine centers are not necessarily bad for the community. Actually, they are not bad for the community at all. There's the safety zones where when you get people who are infected from the community and you want to protect the others, you take them aside into a quarantine where you are going to test them. If they are negative, they go back to the community. If they are positive, you isolate them, you treat them, then you assimilate them back into the society so that you can read out those who are infected, those who can be able to transmit, and that is the only way that you can be able to eradicate this disease from the quarantine. So that is what I have noted. I don't want to go into the murky discussion of the US relations. Why not take to the US? That is more of a political conversation, and it may not help because mine is to dispel fears of Kenyans.
And I agree with you. I agree with you, Kabisa, on the aspect of the community or the people do not understand, or the government has not even taken the initiative to try and make us understand, because
Yeah,
at the end of the day, someone will just think that wanatuletea ugonjwa, they want to kill us. And you
yeah.
see people from Laikipia, like I was talking to a few friends there, they're like, they want to kill our parents because of the immunity that comes with the slow immunity that comes with aging. And as you have established that Ebola is the exposure is really the exposure and the infection itself. Yes, I think Kenyans they don't have a right, but their justifications for worrying, those of us who are worried, are actually justified because we have not taken, or the measures have
They
not
are.
been taken. Yeah,
They
yeah,
are.
they are. Mm. So
And
I
that's
think
why I say that the mistake is government's actually, because it is the
uh-huh,
role of government to do risk communication and community engagement. They are
yeah.
supposed to go to be the ones to allay the fears and tell them that actually we have taken 1, 2, 3, 4 measures to
Mhm.
ensure that this is not going to bring a community infections.
Yeah. And let me
Yeah.
just thinking out loud, why Laikipia? Why not somewhere like maybe Nairobi or Busia? The quarantine will make sense in such regions because of proximity, but that's just my question. Why not proximal areas?
Actually,
Why like
I may not speak for them. I may not
uh,
speak for them, but if I was also to identify a quarantine site,
mm-hmm.
um, a barrack, not necessarily in Laikipia, but a barrack would be ideal because they have a very huge tracts of land. They have areas where you can have it far from where settlement is.
Some people.
There is very good security where you will not have people loitering around and going near those facilities. So it would be an ideal place, and maybe for them, I don't know, but my guess would be then this is an air base. They have an airstrip that can land even in the big planes. It's like an
Yeah.
international airport. So you have a combination of we can we can fly somebody directly from Congo into the Laikipia Air Base without having to pass through JKIA, and then
Okay,
the
yeah.
availability of the facility. But the other thing that people don't know is
Yeah.
that they're also supposed to establish one of the best labs, and I think they call it BL4 or something. The top-notch labs that are accredited to test the level of infectious viruses and bacteria like Ebola. So there is a good side to it. There is another side to it. The problem is that the communication bit was bad. The information came from US instead of coming from Kenya,
Kenya,
and
yeah.
that brought a trust issue, and that is what now we are dealing with. But then that is what I'm saying is that bottom line is that the government is not listening to the people. They should not be sending police. They should be
Yeah.
sending risk communication and community engagement experts. And I
I
think there is
agree.
an army personnel who was trying
Mm.
to do that and successfully so. You remember the one who was able to dialogue with people and people went back home.
Yeah.
That shows, that shows you that the people are reasonable, that if you send people who can actually be able to convince them with authority and with knowledge, they're going to allay fears and all these things are going to come to an end.
Yeah, that's true. That's very, very true. But unfortunately, I don't see that coming because you see now the protests have been planned for back to back every Tuesday. So I hope we
Mm,
are not going to have more deaths and the government can listen. I hope it will change.
true. Yeah,
It
you
will
also asked
change
a
because
question
things people are
around,
scared. People are really
yeah,
scared.
yes, yes.
Mm,
I think your other question was
people are,
surrounding whether we are prepared or not.
yeah.
And I will say that let's gauge that together objectively,
Mm-hmm.
because the preparation is about capacity. The first question
Yeah.
is, do we have the capacity? And I will say yes, we do have the capacity. And I'm
Mm-hmm.
saying this as somebody who has responded to a country with worse off health system than Kenya's. In fact, if you compare Sierra Leone's or Liberia's or Guinea's health system to Kenya, they are like 2 decades behind. So, in terms of capacity, and when you're responding to Ebola, there are several pillars that must come together and work together to be able to eradicate. And these pillars are applied at different phases of the outbreak. In the outbreak, we usually have the preparedness phase. That is when you are at risk, but you don't have a case. And that is where we are. Then you have the second, where you have the outbreak now in the community. And then you have the last one. Now it is coming out of the outbreak, the system strengthening so that you can go back to normal. So we have what we call risk communication and community engagement, and this is just about communicating to the populace and creating awareness about the disease, how they can be able to identify. That is where we come up with the case definition now in surveillance. The second pillar is surveillance, and surveillance, case management, where you have the diagnosis and risk communication and community engagement will go together. And how they go together is that you are going to inform the community about the disease. You make them aware so that they can help you identify in case there is somebody who has that condition, or the people themselves, in case somebody traveled or they had contact with somebody from there, they would know when they are sick.
Yeah.
Then, once they know, they are picked up by surveillance team. And once they are picked up by surveillance team, you confirm using laboratory diagnosis. And we are very lucky we have the National Public Health Reference Laboratory. We have
Mm-hmm.
Camry, can be able to isolate this, and they can be able to do that test without issues. So when we come to the case definition, we usually talk about suspects, a probable, and the confirmed, and then we have a contact. So who is a contact? A contact is that person who does not have any symptoms, but they have been in contact with somebody who was confirmed to have Ebola, or somebody who was probable. Then we have a suspect. A suspect is somebody who may have come from the endemic zone or where that is happening, and they have signs and symptoms. So you suspect they might be having Ebola. That is the person that we usually call a suspect. Then there is the one we call probable. Probable is this suspect. But then the person they were in contact with, they had been confirmed to have Ebola. So you realize for a suspect, they do not have necessarily have to have been in
Information.
contact with Ebola.
Mm-hmm.
Just if they are coming from an endemic zone where Ebola is, if they have been in contact with somebody who is probable, we still suspect them. But a probable one, you know that this person was in contact with somebody who had been diagnosed to have Ebola, and now they have symptoms. And so
Mm-hmm.
that is what we call case definition. And you truncate this and you take it down to the community so that the community understands, and the community can be able to send what we call alerts. We give number, like now we have 719
Mm-hmm.
that is being used nationally to report. And any Kenyan who knows somebody who they think may have been traveled, or they have signs and symptoms that may indicate that they're having Ebola, then they can be able to send an alert, and a team will be dispatched to go to the person and ascertain whether that person actually needs isolation. Then when you get into the main outbreak now, it means you have community spread. You're having people who are already sick with Ebola. These are now people who now you take into the quarantine when they are suspects or probable. That means you have not diagnosed yet. You take them to a quarantine. You take them aside, you isolate them. Then, but we usually call it quarantining. Though in quarantining, you also social distance so that you don't have cross infections. And then from there now, if you are negative, you go back home. If you are positive, you are taken into the isolation facility. That is the one we call Ebola treatment centers, where now we are going to take care of you. And when we take care of you, there are two things that can happen. Either you'll be lucky to come out, and when you come out, then we engage the psychosocial pillar. There's a pillar called psychosocial, dealing with mental health challenges, and reintegrating you with the community. Of course, if you're going to die, now then we'll have the burial team to conduct safe burials, because the burials for the Ebola suspects are not conducted like any other burial. They are highly effective. So the burial teams have to come with the protection. They work together with the family members, and they even provide protection like the protective gears, because we are encouraging that if that happens, then so that the people do not have anxiety, you don't have people feeling that their people are not honored. You can
Yeah.
have the people from the family, the person who is leading, to be involved,
Mm.
including in ensuring the person is in the coffin, whatever rites they need to do, and they are given a PPE. You allow them the traditions that cannot predispose them, that do not lead to contact, so
Yeah.
that then you can be able to go and bury close enough to how they should have buried earlier, but then in a way that actually protects them. So if you look at these pillars, and that is why I
Mm-hmm.
say let us look at it objectively. If we are talking about human resource for risk communication and community engagement, we have them. We have even those who responded in the West African one. If we come to the surveillance, we have a good number, public health officers, epidemiologists, who also responded to the West African ones. They are here, and we have many more who are being taken through a sponsored program we call field epidemiology. And, um, and that means that we have people with the knowledge and capacity. If it comes to the case management, the people who are going to treat you in the ETU, we are there. Myself, I'm one of them. I treated people in the ETUs in Sierra Leone. We have a good number of ourselves, even those who treated during COVID-19. If you come to the burial teams, we have hygienists, we have the people who can be able to conduct the burials. We have psychosocial team. So in terms of capacity, we have the requisite capacity. Now, the preparedness we are talking about is activation of this capacity. And how do you activate? You activate by first conducting a training.
Mm-hmm.
After you conduct a training, and that is what is ongoing. Like myself, I've been undergoing a master TOT training where we are going to train other people who are going to train other people. That is the health
Mm-hmm.
workers. Then you avail the resources that they need to be able to respond. That includes the quarantine facilities, the isolation facilities. There are teams already out there. Some may have
Mm-hmm.
seen them, who are going facility to facility and ensuring that they have set aside some potential isolation areas. I'm also part of that team. From next week, I will be somewhere around Makueni and Kajiado looking at the same. And we are
Mm-hmm.
also now um, even talking to the administration of health in counties to ensure that in every facility, the setup is changed so that it complies with the protocols of Ebola, almost similar to what we were having in COVID-19, so that we can also protect the people coming to the facilities and the community.
Yeah.
And so, if you ask me, I will tell you the capacity is there. The activation is happening. It is on a high gear. And let me assure Kenyans that if we were to get an Ebola case today, we will be able to eradicate it
Manage
at
it.
source. We'll be able to quarantine at source. We'll be able to ensure that we do not have an extended community spread of the same. Yes,
Now,
Lily.
Doctor. Yes, now you have said that if we get a case today that as a country, and let me just remind you our behaviors as Kenyans. We do not
Yeah.
listen when you are told to take measures. We do not listen when you are told to be very hygienic. We saw it with COVID. How are we going to ensure that, sasa, with our cases that we have, that it does not spread? Consider the fact that, are we looking at a looming lockdown or something like that? Because how are we going to isolate cases? How are we going to make sure that aisongi ikipatikana, considering our behaviors and our patterns and our habits as a people?
Yeah, of course, behavior change is the first thing, and that is why we
Mhm.
need the risk communication and community engagement pillar as a pillar that comes before the outbreak during this preparedness. And you'll be seeing them very
Mhm.
soon, going to the markets, going to the bus stops, going to churches, and everywhere. And we are actually
Okay.
encouraging, once you get this information, if you are going to church on Sunday, if you are going to church on
Mm.
Saturday, Please ask for
Mm-hmm.
some time and educate them and tell them we are going back to the COVID protocols that we were using. That
Mm-hmm.
keep hygiene, wash your hands, ensure that if you're sneezing or coughing, you have your mask.
Mask,
Try
yes.
as much as possible to social distance. That may not make sense now, but
Mm-hmm.
once the outbreak is here, then that has to be enforced. And of
Yeah.
course, people are going to reciprocate once they see genuine need. And once the
Mm.
outbreak is there, that is going to happen. So behavior change is something that can happen if, like in West Africa, they eat monkeys, they eat rodents, even cats, where we were. They usually washed their dead bodies. And in some communities, they will actually wash, rinse, then the water they rinse with, they drink. Some very funny,
Ah,
funny practices. Yeah. And you can imagine there was behavior change, and these people, at last, they complied. So if you can move people from some of those behaviors into the
mm.
behaviors that are going to protect them, how then is it impossible to move Kenyans where literacy level is very high and people are going to
Yeah.
understand what they are telling them? So for me, I think we are a better place than those countries.
I also think we're in a better place than most countries, most African countries, of course, but lazima tupige kelele, you know. Now we have some few questions in the
Yes,
comment
yes.
section. Sulemana is saying, as a PhD candidate in public health nutrition, he's interested in understanding the relationship between Ebola virus disease and nutritional outcomes. Are there any recent findings on the role of nutrition in patient recovery and resilience during Ebola outbreaks? You can respond to that, and then we also have another one from him. I will also read, or you respond first, then I read that because it's a
Okay.
bit long.
Yeah, a good question from Sulaiman. I may not have looked at the research, but what I know as a clinician is that the correlation between your immunity and nutrition is something that you cannot ignore. Good nutrition, better immunity. And Ebola does not have definitive drugs that you are going to give and somebody is going to get well. It is your immunity that fights for you. So it is time, especially during preparedness. This is the highest time that the nutritionist then should be out there advising people on the kind of nutrition that boosts your immunity, so that then that gives you a better chance in case you get infected. So there is a direct correlation, but and of course, during the disease, the correlation is also there. Clinically, I can tell, though I may not have looked at the studies, because it affects the GI tract, it affects absorption. There is a lot of vomiting, you lose a lot of nutrients. And so that means that when your absorption is deranged and you're vomiting and diarrheaing almost everything, and then you have a lot of exudation, water from the tissues coming into the gut and then going through the diarrhea, you're also losing a lot in terms of nutrition. So it really affects. It's something that you can correlate clinically, but I think if you look at studies, I don't know if there are studies that have been done.
No, studies on Ebola are a bit limited for obvious reasons because it's not a common occurrence, but it's clearly a repetitive. I think we should have more studies on that. Maybe
Yeah.
Sulemana, you can take that up and do a review of what is available, then you can share with like to read. But again, we can also do that for you. He also has another question, another list of many questions. So I think maybe he was not in when he was talking about the current status of Ebola. So he's actually asking what lessons have been learned from the recent Ebola outbreaks in Africa. What is the current status of Ebola vaccines and treatment? You talked about that, but if you don't mind, you can just repeat for him. And how can communities be better engaged in Ebola preparedness and response? I would also like to know about your community engagement because we say, of course, as a country, we know our habits, the way they are, we know we will resist. Of course, we have to resist first. When you are being told that tufanye hii, tuvae mask, tutasema hapana, hiyo ni maneno ya hii serikali, we must resist as Kenyans. So how are we going to, like, on a broader picture, how can we improve the community engagement and involvement when it comes to Ebola response and preparedness? And what are the major challenges that we expect when it comes to detecting and controlling Ebola outbreaks? These are some of the questions that are coming in from Sulemana, so maybe you can respond to that as we continue. And he's also talking about remote areas, which is okay and which is good. So you can also share some of the challenges in remote areas. And another one is, how does Ebola affect nutrition? That one you have talked about. What role does surveillance play in preventing future Ebola outbreaks, and how can healthcare workers protect themselves um, while responding to that, the comment section, I think in a jar, so it's shorter. So I think I also, on the part of healthcare workers, you've said that as a healthcare provider, when you go to those stations, the quarantine centers or the regions where there's Ebola, if you want to go home, is that part where you have 21 days of quarantine or isolation yourself. So that, as the mentor, I was watching your interview the other day with the other lady who's a psychiatrist, and she really highlighted on the importance of psychiatric care for even the healthcare providers. But how prepared are we to take care of our healthcare workers? You are there, and I'm sure you experience a lot of issues and a lot of stress. So, how prepared are we to make sure that our healthcare providers, when they are responding to Ebola, do not get through that?
Yeah, thank
The
you. And
question.
very good questions from Suleiman. And the most loaded is what lessons did we learn? And good
Yeah,
enough, I must say that when we were coming from West Africa, we did a very good report with recommendations. And it was kept somewhere in a drawer gathering dust until 2020 when we had COVID, and that is the time we were being asked, where was the report? What did you recommend? That's sometimes we don't take some things seriously until they are now facing us. We learned quite some lessons, and the biggest one is preparedness. Preparedness before you get the outbreak. Preparedness is everything. In fact, whatever we are doing now, before we get an outbreak, will determine how the outbreak is going to affect us. If we prepare enough now, it will mean that we get the index case, and probably it ends at that. And probably the contacts, a few of the contacts who may also contract the virus, and that will be it. That will be it with Ebola in Kenya. If we do not prepare enough, we are going to get community spread. And that answers now the second question: how does surveillance help us with the future outbreaks? So the work of the surveillance is, once you know that there is a virus, there is an outbreak somewhere, the work of the work of the surveillance is now to survey. Are we having people who are coming from that zone into our zone, or people who are going from our zone to that zone, getting in contact with the people who may have the virus and coming back? And once they bring that information, that is now the information that is usually used to gauge the risk that you are at. And now, once you gauge that risk, of course, now you are going to take administrative measures. They can be the lockdowns, you can cross the borders, you can cross the airports, and what have you. But what we have seen, especially with the porous borders like ours, and where you have people coming through other routes, that may not work. And that is why we keep on saying that surveillance is not 100%. You can still get the cases. That is why even with the best surveillance systems, you must be prepared to have the cases and how you are going to respond to the cases. We say you prepare for the worst, and then of course you pray for the best. How do we protect our health workers? I think today, if you are going to look at the news, there will be, if they are going to show, I think today they were taken through the protective gear and how you don or wear and doff, remove. I think it will be shown in the media. And basically, for health workers, there are levels of protection. One is when you're in the facility and you are triaging people, and there is a possibility some may have. You are supposed to be in a PPE that we call light PPE. Then you must have a desk that is at least 1 meter that separates you from the patients 1 meter, and you do not get into contact with the patient without a PPE. If you need to examine the patient, then you have to don in the full PPE, because we have the light PPE and we have the full PPE. Then the other issue surrounding that is about mental health. You have to be in your best mental state. So there has to be debriefing sessions, the counseling sessions. You have to be in good health yourself. If you're sick, you're not expected to be appearing at the workplace, especially where you have the ETUs and the response surrounding Ebola. And of course, there is the insurance covers, so that in case you're sick, you can also be treated. We also work in a buddy system. In Ebola, we say it is like a war zone. There is no soldier who walks alone. We are comrades. So we call ourselves buddies. And even when you're going into the ETU, you never go alone. You must go in 2 pairs. And anytime you are in the red zone, in the ETUs, you have the green zone, less infective. Then you have the most infectious, the red zone. There is usually a screen, and even when you are two of you inside, there is somebody observing you from outside. And in case they see as if probably you are going to infect yourself, they are mandated to call you out. And if they cannot call you out, they can actually don in the PPE and come and get you out of there. So we ensure that the protection is high gear, and the priority is to keep the people who are not infected like that. And of course, those who are infected, we do our best to ensure that they recover, that they do not die, and we can reintegrate them with the society. I don't know if I have missed a question, Lillian. You can remind me.
No,
Okay,
you have
so
actually answered all the questions that we have asked. So I
Yes.
think yeah, you because he talked about nutrition, he talked about preparedness, and you also talked about protecting the healthcare workers. And I think that is all that Suleiman asked for. I hope, Suleimana, your questions have been answered. If not, you can also give us another comment, and I will read it out loud for our speaker to engage you. So yes, we are prepared as a country, but there's room for improvement. I think that is the truth, Daktari. Even if you say that
Yes.
if an Ebola a case is identified today, we will not have a pandemic, or we will not have an outbreak. I think understanding the way we are as a country, of course, your part, your communication, there is a lot that needs to be done. There's a lot because we
Yeah,
have a
we
lot
have a
of
lot of deficiency in that, and that is why
mm,
Kenyans are expressing fear. You know what Kenyans are expressing now is fear,
yeah,
and
yeah,
fear is from lack of facts. And how they are to
yeah.
get facts is through community engagement. And that's why we have come out and told the government that you are doing the wrong thing. Stop sending the police and start sending the experts who can be able to talk with people. They reason together, and they are going to, of course, convince them regarding the issues, because our people have a good understanding. Their literacy level is very good. So we are not 100%. I'm not trying to say that we are very ready, but I'm saying, being that we are in the preparation stage, we are taking the right steps. And even for Kenyans, I like the fact that everybody is talking about Ebola. They make it very easy now to be able to pass that message, to be able to pass the facts, to be able to um, to demystify fears and what we call infodemics, that is the misinformation and disinformation. And once you do that and people have facts, then they become confident about the protective measures. You're going to see that fear dissipates. And when it does, then we can have a very objective conversation. And I won't say that we are at a better place if I know we weren't, because for those who do not know, I'm a unionist. I usually do not fear saying the truth. It is that I also looked at, and I think he asked about the lesson. Let me give you some bit of history from Sierra Leone and how the spread happened. And you'll understand why some of us decided not to go to the other side and decided to come out and talk with Kenyans. When we went to Sierra Leone, what we learned is that the reason the virus spread very fast is because it started in the non-dominant tribes, which are not influential, and they were not in government, they were in the opposition. And so the rumors then were that it has been brought by the government to finish those who are in the opposition. And when you go to the facilities, because the fatality rate was very high, they would say that it's the medics who have been instructed by the government to kill them. So they shunned facilities, they attacked medics. Medics also started dying from Ebola because they didn't have the requisite protection. The hospitals were abandoned. And so when I saw politicians coming out and politicizing the Nanyuki issue, creating a lot of fear, I also came out and I was saying, this is like deja vu. If we let this happen and we get cases in Kenya, then we are going to get into the same scenario that we had in Sierra Leone. And it will be gullible for, for ourselves who are there, or a betrayal to our people, if we would have something that we can say is taking us in a wrong direction, and then we'd be the same people to either allow its propagation without saying anything or join them and propagate. And that is why we analyzed the situation and said, we must have the right conversation. And we came out and said, we need to have the right conversation. People need to know about Ebola. They need to know that quarantine and isolation facilities are actually safety zones. They are good for the community. They are not bad for the community. Because the message that was being sent out there is that a quarantine facility is actually bad for the society. But that actually is misinformation and sometimes disinformation because it's deliberate.
Yes. Doctor, if I was not in healthcare, I will also be singing the song that that facility is a bad idea, because the naysayers or the people who are opposing it are actually very vocal and very loud in making sure that they get their messages to Kenyans. Wanaisambaza vibaya sana. It's all over that now the government. In fact, there was another, I'm sure you saw it somewhere, where there is a meme that was going around that the president is actually importing this Ebola so that when Kenyans are going to vote, they all die. That is why it's coming up. So the propaganda is real. The misinformation is also very, very real. So I think even as we prepare when it comes to matters capacity, the aspect of communication is very important, and mass communication for our people, because Kenyans will react. And if we don't know, the reactions can be very volatile. You see, like the other time that the suspected case in AAR, it was all over, like negativity, mpaka like people are saying now, see, we have, and the facilities is not yet even running yet officially, but they were like, now they have lied, the facilities going on, that's why we have this. I saw that in several groups, and it was the conversation, you could see it was Nikubaya, the misinformation is bad. So I think as you go back to now making sure that we are being educated, we are getting the right information, we are strengthening our capacity, we should also focus on engaging the community so that if it happens, tunaweza kuikatail as a country. Yeah. I think that, yeah.
And I must also thank Kenyans, because there are so many alerts going to the Public Health Emergency Operations Center. There are so many alerts from Kenyans who are saying, I think this person had traveled, I see they have symptoms. Some of the people calling themselves, And that is how so many people have been tested and it has come out negative. So that is a very good response from the community.
Yeah.
Yeah.
And I think you should also encourage the community people, if you suspect that you have it, usiogope. Also, like, you remember during the COVID times, people were
Yeah.
being scared. Mtu akishikwa na symptoms, they would lie, they would hide because they did not want to be isolated. People do not want to be in quarantine. So I think, in as much as, yes, it might get lonely out there, but it's also protective for you because you'll be getting treatment as an individual and you'll be protecting your loved ones. The more you expose yourself, the more you expose your loved ones, and the risky it is for them. And I hope
True.
that when it comes to treatment, we are still okay. Because I was reading on Ebola the other day, and of course, asking questions like, why not the political questions, why the US could not select other countries, and they were like, they have to have a country where they can bring their own treatment to their own people because they don't trust what we have as a country.
And, the
Yeah,
other fact is that in East Africa, Kenya has the best health system. I don't think
yeah,
anybody can contradict that.
that one I am aware, but I'm telling you, the propaganda out here, the propaganda is real. The propaganda is real because it's
Yeah.
also something that has trended and it has a lot of views. I'll
And
share with you that.
what people should also know is that the sick ones are not going to be treated in Kenya. Kenya is just a quarantine. Quarantine is when you are suspected, but it has not been confirmed.
Yeah.
What they had agreed was that once it has been confirmed, you are to be shipped to Germany. So there is
Yeah.
no confirmed case that will be in that quarantine. It is only the ones that have not been confirmed.
Kabisa. I also saw that watapelekwa kwa the treatment centers in Berlin, which is in German, which is a good thing. But again, you see, no, not majority of Kenyans will not even dig that deep. Wataenda tu waangalie hizo video za watu wakireact za kina Mwecheche, and that is what they will ride on. So
Yeah.
maybe as you do the
I've even
community
seen a lot of misinformation and disinformation. Some of them saying it's arsenic poisoning, and people are
Mhm.
being poisoned using arsenic and being told it's Ebola. There's we usually say that a rumor travels half the world before the truth can
Yeah.
even start. And when you're
Yeah.
dealing with an epidemic, you must also deal with infodemics. Infodemic is the
Mhm.
misinformation and disinformation. And it
Yeah.
always crowds the space before now you can be able to get to the people.
Yeah, that one is true. That one is true. So we hope for betterment, and I hope you
Yeah.
guys have heard that Kenya has the capacity. Kenya has the capability. You can have the capacity, like capability. Hakuna tuko na capacity. We have healthcare workers. We have community experts, as Daktari has said, and they're also training so that they can be able to handle it. And also this time, I think if I'm not wrong, we'll also be exporting health workforce to mitigate or to help others fight. But I hope we'll not export the best. Tutabaki na the best and then we export the rest. Kujipenda kidogo.
Yeah, I know the NGOs that are already recruiting, and
Mm-hmm.
some of them may go, but not all of them are confident enough to go to the red zones, to the
Mm-hmm.
endemic zone. But I think a few of them may actually apply and go. And
Mm-hmm.
I can tell them that it's a very good experience. I think the experience I got in West Africa is a lifetime one. And
Yeah.
if I must go to Congo, I will, because I've been
Allah,
there and I've come out.
even with the deadliest strain.
No, actually,
I
this
like.
is not as worse as Zaire. This is less aggressive than Zaire that affected West Africa.
Oh,
The
okay.
reproductive rate of this, the RO, is 1.6. And 1.6 means the reproductive rate is one person can infect how many people? This one is for two people. One person can infect two people. So the multiple infections are usually driven by stigma and fear and people refusing to come out. Do you know that measles has a higher reproductive rate than in the arrow? I think one person with measles can transmit to about 8 or 9, but we are never concerned. Flu is
But we
even
have
high.
corona vaccine ya measles.
Yeah, I know. And what I'm trying to do,
Mm.
I'm trying to dispel fears and tell people
Mm-hmm.
that if we take measures as we are being advised, yeah, if we come out on time, we can actually be able to save ourselves from Ebola, even if it was to come. But we pray
Yeah.
to God that it doesn't land here.
Yeah, we also pray so that at least sasa tuende tusaidie wenye wakwenda waende wasaidie others outside there and Kenya tubaki tu vile vile. But if it comes, you people have had the government, the healthcare system is doing what it's doing its best to make sure that we are protected. Actually, I'm not as scared. I think with COVID, I was a bit more on the misinformed part. So I think I panicked more as an individual when it comes to COVID than this Ebola. Ebola, I think ni hiyo tu misinformation na hiyo story ya kusikia ati now. Of course, hiyo part yenye ulikuwa unasikia ati the regions where we are not going to vote for the government, tutatupiwa watu wako na Ebola. Of course, unaogopa kidogo, but we also know hiyo ni propaganda, eh? So let's shy away from propagandas. Let's shy away from myths. Before you get before you start sharing something, please get information. And also, as the other part of, you are our comrade on this side, na pia uko the other side. So when you step into the other side, please talk to them about sensitizing the community. Kwa sababu hiyo ndio italeta shida the most. Itaharibu capacity, itaharibu capability, ita make sure things are going south, because if people don't believe that it's been done for their well-being, that's why people are rioting and having no one wants to have their mothers exposed to a deadly disease. If your mother is 60 and unasikia disease inakuja, it can kill her in less than 3 weeks, you'll not want her to be exposed to it. So let's
Very
try as much uongee tu wajaribu so that hiyo misinformation iende, and we hope and pray for the best. So maybe you can share a parting shot juu masaa imeenda.
Yeah, and I think my parting shot will be facts over fear, or facts, not fear. Please get the facts. Try and separate the facts from fear so that then you'll be in the right trajectory to protecting yourself. Ebola is a disease that can come to Kenya, and when it comes, also, facts help you not to panic. Do not panic. Just take protective measures in case you feel that you might be having the disease, you have come into contact with somebody who might be having the disease. Inform us. The toll numbers are there, and you can actually be able to recover. And with early intervention, even the one we are saying case fatality rate of 26 can even come down to less than 10. And we saw that in West Africa. So it is not as deadly as it is. It is only as deadly when then you ignore it and come at the later stages. So thanks a lot, Lillian, and your crew, Charity Wanyonyi and the others. You are doing a very good job. Please continue educating
Thank
Kenyans.
you. Thank you. Thank you. You're very welcome. And thank you for honoring our invite. Najwa, you have been very busy, and to create time, we are actually very much honored.
My
So
pleasure.
the toll number that Washira shared is 719, if I'm not wrong.
Yes, it is 719.
Daktari.
Yes, it is 719.
Yeah, 719. So that's the toll number. If you or your loved ones suspect that you have been exposed, alafu we go back to the COVID times. Let's take hygiene. Tuanze kung'ara na masks. You remember in COVID tulikuwa tunasema hiyo ni accessory, ni part of our dress code. Let's go back to there. Let's go back to taking hygiene measures. I think it should be something that we do continuously, but it shall be well. It shall be well. Before we go, Daktari, there's a last comment. Allow me to read it. Suleiman is saying thank you to the organizers. Karibu sana, you're welcome. The information shared was insightful. Daktari, you've shared a very, very value-packed. I know it's been short, now I've cut you short, but we are going to have the conversation. I hope we are going to get you available another time. So it was very insightful, and Suleiman is saying, I particularly appreciate your efforts in addressing important issues such as Ebola prevention, community engagement, and combating misinformation. Your expertise and dedication to public health are truly inspiring. Thank you for creating this valuable learning opportunity. Thank you so much, Dr. for creating time. Thank you for the insights, and thank you for educating us. I have learned a lot myself as a host. So I can also imagine the rest have also learned a lot. And that is what we are all about. Asante sana, and we are hoping to see you another time for our discussion. Thank you. I think we'll call it a night, and you can share some of the questions that you have. We'll address them as well as we continue. Good night, Tini.
Good night, Tini.
Oh my God.
Good night. Good night. Yeah, we have a very beautiful guest there.